Good afternoon, everyone. Thank you very much for your invitation to participate in this session. My research career has been focused so far on how to improve cardiac output during CPR and how to improve sudden death outcomes. I have recently received my PhD on the study of incidence and risk factors of CPR injuries and their hemodynamic adverse effect. In the next 10 minutes, I will try to explain why I think it is important to work towards a more personalized chest compression performance and ventricular fibrillation treatment. I have no conflicts of interest. I am the principal investigator of the RECAPTA study. We have received funding from the Catalan Resuscitation Council. I am from Tarragona, a very nice region of the Mediterranean area, with a good weather for the practice of tennis sports. As a regular tennis player, I hope that this lecture will lead, like in a good match, to a good set of questions in this case. We are facing many challenges in resuscitation research. One of the main is the drop over time of cardiac output, even with the use of mechanical chest compressors, impairing the benefit of new treatments as ECMO. The chest compressions is our tool to produce cardiac output during CPR. That's why it's so important to optimize them. In our simulation model, we can see the movement of the sternal hinge and how the costal cartilage is deformed. But it is the anterior axillary line of the ribs which has a higher risk of fracture. The human ribs biomechanics behavior is depicted on an elastoplastic force displacement curve. A rib fracture produces an elasticity loss. Recent data highlights the need to maintain the elastic properties of the chest during CPR. A higher chest compression release velocity was associated with higher probability of survival. A drop of chest compression release velocity was larger among women and older patients. The guidelines aims to balance the benefit of increasing chest compression death against the risk of causing harm. On one side of this balance, it was described a higher incidence of CPR injuries with more than 60 millimeters of chest compression death. On the other side, a large study reported that maximum survival was associated with chest compression death between 40 and 55 millimeters. Not without this caution, the last guidelines established between 50 and 60 millimeters the recommended depth of chest compression for an average-sized adult. Concerns about the one-size-fits-all approach for CPR performed by specialized teams are growing. Another study has assessed the optimal compression depth. It has been found an optimal chest compression depth of 47 millimeters, associated with a higher survival. Older individuals appear to benefit from a shallower chest compression depth, but differences were not significant. We have more data available to assess the benefit of the chest compression depth than data to assess the risk. We have some definitions to assess the risk of harm, such as life-threatening injuries, serious ribcage damage, serious visceral damage, and major traumatic injuries. These different definitions, with a wide range of incidence, makes it difficult to assess the real risk of harm of CPR injuries. In order to help with this, we have introduced the concept of serious CPR injuries with an adverse hemodynamic effect. We review and analyze this issue using the Campbell diagram, highlighting the need to preserve the elastic properties of the chest to maintain the key negative intrathoracic pressure during the decompression phase. Now let's talk about some results of the RECAPTA study, which is a prospective out-of-hospital cardiac arrest registry including multiple sources of information for the study of sudden cardiac death. It includes a specific protocol for the study of CPR injuries. We studied the incidence of injuries due to manual CPR. We found that 63.3% of non-survivors presented serious ribcage damage. The median of rib fractures in this group were 8, and 87% of the cases presented bilateral fractures. Regarding the CPR injuries risk factors, the ones more commonly described are the age, female sex, duration of CPR, and depth of chest compression. But in our study, Thanks to our specific protocol, including the anthropometrical variables, we found risk factors beyond the classical ones. In our multivariable regression analysis, the chest circumference greater than 101 cm was the only risk factor associated with serious ribcage damage, and female sex was the only one associated with serious visceral damage. These findings features the importance of the chest geometry over other risk factors. But why does it happen? Because women with age present a horizontalization of the ribs and men instead present a horizontalization of the ribs with the increase of the abdominal perimeter. In these cases, an increase of stiffness and fracture vulnerability occurs. Few words about the resuscitation in big-sized patients. Studies have shown worse outcomes between them. Due to many reasons, this is one of the most difficult resuscitation. The increased slope of the sternum leads to slides of the hands that could produce serious injuries. On the other hand, the ventricular chambers of the obese patients are displaced to the left. We have reported some first favorable results about the safety of a displaced compression, but more data are needed about the safety of a displaced chest compression point that could be optimized using ultrasound images. Now let's take a look at our new results. We studied the chest compression force variation from the mechanical compressor Lucas 2, and we found that most of the patients presented a high force variation over time. The high compression force variation was associated with a higher incidence of ribcage damages as bilateral rib fractures. The reason of this is very interesting. Ribcage damages breaks the equilibrium between the elastic and the damping forces of the chest due to a loss of the chest wall elastic force. What are our suggestions? Taking into account the data available to assess the risk and benefit of the chest compression depth and the lower chest height in women, we suggest for older women a chest compression depth between 40 and 50 millimeters. And for big-sized patients, such as obese, we suggest that extreme precaution should be taken. Regarding the refractory ventricular fibrillation treatment, the survival decreases with the number of defibrillation attempts. However, there is a chance of survival even with more than 10 shocks. That's why this has to be balanced considering the benefit of transport to the hospital with ongoing CPR. These findings highlight the need to extend the quality of CPR during the first defibrillation attempts. Regarding the defibrillation treatment, this case shows for the first time the variation of the end-tidal and AMSA prior to 12 defibrillation attempts. As you can see, the two returns of a spontaneous circulation of the minute 28 and 39 were preceded by an ascending trend in both curves. We suggest that the real-time analysis of both curve trends could help selecting the timing of defibrillation to avoid unnecessary shocks and improve outcomes. Finally, some words to conclude about variables in personalized research. The patient's gender, age, size, the biomechanical behavior of the chest, such as the compression force variation, the hair size and position, and hemodynamic variables, such as the intrathoracic pressure, need to be taken into account on personalized CPR research. Our research focuses on the biomechanical behavior of the chest, offering a new point of view to improve the effectiveness of CPR. Research to assess CPR injuries harm to preserve cardiac output over time can help guide a more personalized CPR. I think that research on personalized CPR will give us the opportunity to make great improvements in cardiac arrest survival outcomes. Thank you very much for your attention.